As you've heard from Dr. Shim, stroke is a common disease affecting about 800,000 people a year across the United States. That's 1 every 40 seconds, and it's a deadly disease with a death rate of that ranges about third or fourth in the nation behind heart attack, cancer, and respiratory disease. There's two varieties of stroke, as Dr. Shim previously mentioned, ischemic and hemorrhagic. We're going to concentrate on ischemic, which is, in our practice, most commonly due to atrial fibrillation and embolic ischemic occlusion of vessels. Ischemic stroke is by far the most common variety of stroke, affecting 87% of all comers. But ironically, out of all these people that have this deadly disease that is frequently seen, we only get to treat about 1% of these, and the main reason for that is most of them don't get into the hospital in time for treatment. TPA, as Dr. Shim mentioned, is the gold standard treatment for stroke if the patient gets to the hospital in time. Usually that window of time is 3 hours, but now more recently has been pushed back to 4.5 hours. And TPA is tissue plasminogen activator. It basically breaks down blood clots into particles which then get absorbed or potentially migrate distally. Again, only 8% of ischemic stroke patients are eligible for this treatment, though, because most of them don't get to the hospital in time. The other problem with IV TPA is there's a lot of contraindications for its use. If someone is on anticoagulants, if someone had recent surgery or a lumbar puncture, if someone has a coagulopathy, or if someone wakes up with stroke symptoms, then they basically fall out of that treatment option and then fall into our hands, which is endovascular treatment. The other problem with TPA is that it doesn't work very well in large blood vessels. It works great in smaller blood vessels, but big vessels like the internal carotid artery, when acutely occluded, IV TPA opens that vessel up only about 6% of the time, which is pretty miserable because that's a devastating stroke. The middle cerebral artery or the vertebrobasilar system likewise only gets opened about 30 or 40% of the time with IV TPA. And these sorts of strokes are not that uncommon. They represent about 30 or 40% of strokes across the board. And finally, if left untreated, they're very devastating strokes. An internal carotid artery occlusion will kill you about 50% of the time. A middle cerebral artery occlusion will kill you about 30% of the time, and a vertebrobasilar occlusion gets you almost all the time unless rapid treatment is instituted. Looking back at various studies evaluating whether or not opening up blood vessels in acute stroke is a good idea, it's very clear that revascularizing the cerebral beds gets you a better outcome. And in this case, better outcome is defined as functional independence. So if you revascularize a stroke, you have about a 58% chance of being independent versus 24% if it doesn't get opened up. Mortality drops precipitously from 41% to 14%, and interestingly, the symptomatic intracranial hemorrhage rate doesn't change that much. So opening these vessels seems like the right thing to do. Luckily, TPA works pretty quickly, and these infusions are given over 1 hour, and at the end of an hour, you have a rough idea of whether or not the TPA is going to do the job. During this period of time, about 50% of people that get TPA seem to improve in some way, whether that's a resolution of the blood clot or improvement resulting in partial blood flow. So a patient coming to the hospital has a few different paths they can take. If they get there too late, they get medical management, which is basically just supportive care. If they get there within the 4.5-hour window, they get IV TPA and watchful waiting. If the patient doesn't improve on IV TPA, then they come to us. If they come outside of the window, over 4.5 hours, then they come directly to us. And the procedure in terms of opening these vessels is very similar to cardiac catheterization. We go in under conscious sedation through the femoral artery. We run the catheter up into the aorta and perform contrast injections and get good angiograms of both the neck and the head. At Tri-City, we have a lot of older patients, and one of our biggest challenges in these procedures is just trying to get to where we need to go because older patients have more tortuous blood vessels, and sometimes we can't even make it up to the brain to treat the stroke. Once we get there, the goal is to open up the blocked blood vessel so that oxygen and nutrients can get to the affected territories. And here's another before and after shot of middle cerebral artery. Here you can see, back up there. Here you can see the internal carotid artery here. It breaks into a T. It goes up into the anterior cerebral artery to the right, and the left goes over to a middle cerebral artery, which is occluded by embolus there. And then following treatment, successful treatment, you see marked improvement and perfusion of the middle cerebral artery territory. We've been treating stroke endovascularly probably for about 10 or so, maybe even 12 years. And we started out just by running a microcatheter up into the brain and delivering TPA directly into the clot, which was safe and effective and quick, but not effective enough. I'd say it probably allowed significant improvement in, I would guess, around 25% of cases. Since then, there's been a variety of devices that have been developed that have really markedly increased our ability to get rid of these clots. And Dr. Shim talked about the Stent Retriever, which is basically a snare that is delivered through a microcatheter in the brain. We advance the retriever into the clot, and there's a sheath in the carotid artery that has a balloon on it. So we can actually arrest flow in the carotid artery, and then as we pull that snare back into the carotid artery, we're sucking on the sheath so that all the blood and hopefully embolic material gets sucked out of the patient. Unfortunately, it's kind of a difficult procedure to perform. There's a long learning curve. Recanalization rates are around 50% or so. These procedures could take 3 or 4 or more hours to do, which is important because you're talking about someone in whom time is brain. And multiple devices would sometimes need to be used. Subsequent to the Stent Retriever, this Penumbra system came out, which is basically just a tube and what's called a separator wire, this device here. As you pull this device through the clot, you move the separator wire, and that breaks up the clot and sucks the clot out. But a lot of times what it really did was basically break up the clot into little pieces that would then go downstream and block up smaller blood vessels, which sort of defeats the purpose. Both of these devices were featured in some recent studies that raised the question of whether endovascular treatment was really a good thing for stroke. Future trials, I think, will focus more on the newer generation of stroke devices, these Stent Retrievers. And these are really, they've only been out for about a year or two now, and these have really revolutionized our ability to treat stroke for a variety of reasons. The Stent Retriever is basically just a nitinol self-expanding stent that is welded to a wire. And so we advance a sheath again into the carotid artery. We advance a microcatheter through the clot. Usually we deliver a few milligrams of TPA directly into the clot to soften it up. And then we deploy this retriever across the clot. The clot gets stuck on the retriever, and the retriever, as we suction the sheath, we pull the retriever back. And now with the retriever, we're able to get the clot out probably around 80 or 90% of the time. It's relatively easy to use. It has a predictable outcome most of the time. And probably most importantly, we're able to shorten procedures times and get the circulation going faster. So I'll take you through a patient presentation. Patient comes to the hospital. The first thing we do is get a non-contrast head CT for a couple reasons. One is we want to make sure there's no hemorrhage, which would contraindicate intra-arterial thrombolysis. The other is we want to make sure the patient hasn't already completed a stroke, in which case thrombolysis is useless. So we get the non-contrast CT. This is, say, a patient with hemiplegia and aphasia. Sometimes on the non-contrast CT, we'll see a finding that helps us determine what we're dealing with. And in this case, there's a dense M1 sign. So this is the middle cerebral artery here, coursing out to the territory that it perfuses. When flow slows down in that artery or stops, it turns up as a density on CT. And so we know in this situation we're dealing with a large vessel occlusion. So while the patient is getting IV TPA, the gold standard treatment, assuming the patient got to the hospital within the 4.5 hour window, we get a CT angiogram so that we can, for a few reasons. One, we want to delineate exactly what we're dealing with. Is this a big clot? Is this the entire hemisphere that's clotted off? In this case, you can see that there's a filling defect in the middle cerebral artery. There's relatively good collateral circulation, which is important because when you block off a major blood vessel, sometimes the smaller blood vessels do a pretty good job at keeping the brain alive until you can open that major blood vessel up. Another way of looking at this in the coronal plane, here's the normal side with the carotid artery coming up and breaking into the anterior cerebral and middle cerebral. On this side, it's just missing. So that's a big clot that's filling up the origin of that vessel. And then this is a 3D reconstruction, just another way to look at the same thing, but there's definitely a missing piece there. So as we described before, this patient would go to the angiography suite, get prepped, usually get some sedation, especially if they're moving around a lot. And then we advance the retriever up into the clot, hopefully aspirate the clot and restore flow. And these are images of what it looks like in actuality. Again, the carotid artery coming up here, a meniscoid filling defect right here where you'd expect the middle cerebral artery to come off. Here's the anterior cerebral filling over here. And then when this is an image with the catheter, which you can see kind of coming up through the siphon and then out through the clot. When you deploy this retriever, it sort of partially opens up the artery most of the time. So the clot's still there, but now you're at least getting blood flow, which is great because now you're saving neurons. So this thing is left in place for about 5 minutes as the clot kind of gets incorporated onto the stent and then gets pulled out. And in this case, ends up with a great result, with basically a normal-looking angiogram. It's pretty remarkable when you see this happen in real life. It's just kind of makes you feel good. The other thing that makes you feel good is when patients do well after this. So sometimes on the table, you'll pull the clot out, and they'll go from being hemiplegic and aphasic to normal. They'll sort of shake their head and look at you and say, what's going on? All of a sudden, when they haven't been talking before the procedure, and they start moving the part of their body that was previously paralyzed. It's pretty amazing to see. Unfortunately, that's not always what we do see. So adequate revascularization or clinical or technical success doesn't always equal clinical success. And there's a couple reasons for that. One is bleeding, which Dr. Shim touched on. But the other is that time is money in this business. And basically, if the patient has already infarcted the tissue that's supplied by the vessel that we're opening, then opening the vessel really doesn't help them at all. In fact, it may hurt them by increasing their risk of hemorrhage in that territory. So a core infarct is an area of brain that has not received adequate blood flow and has died irreversibly. Can't fix that. But there's an area frequently behind these occlusions called the ischemic penumbra, which you can fix, and this is the brain at risk. So someone that has a middle cerebral artery clot, if the collateral circulation is good enough, those brain cells may be viable, and if you remove the clot, then they sort of come back to life once adequate blood flow is restored. The crux of this problem, though, is that we don't know which patients have this ischemic penumbra. It's very hard to tell who is irreversibly infarcted and who still has brain that is at risk but salvageable. And different people respond to a blood clot in various locations despite the fact that these clots sort of look similar in various patients. And that's probably based on collateral circulation. Some people just happen to have great collateral circulation, and if you occlude a big blood vessel, then small blood vessels do a good job at taking over for that. But other people don't, and so the people that do have this great collateral circulation, you could probably treat outside of the currently specified windows, because their brain cells are salvageable for a longer period of time. Some people have horrible collateral circulation and have already infarcted even though they're within the window of treatment. What do we do with wake-up strokes? Those strokes may be 10 minutes old or they could be 10 hours old, and it's very hard for us to determine which of those patients we should treat. Similarly, posterior fossa strokes, these are really devastating strokes. A basilar occlusion can cause locked-in syndrome, which no one wants. And the posterior circulation tends to be a little more forgiving in terms of duration of ischemia. So the question arises, should we be treating these patients farther out than the window suggests? And sometimes we will treat a basilar thrombosis out to 12 hours or 24 hours or 2 days. What we're hoping is for advanced imaging techniques to help us with this problem. And there are a couple of them out there right now, such as CT perfusion, MRI diffusion or perfusion, and these are studies that help or try to quantify the amount of blood flow that certain areas of the brain are receiving, but they're not perfect yet, and so we're still still looking for a better study to guide us and help us determine which patients we should work on and which patients are too far gone to treat. So at this point, we're left with the American Heart Association recommendations, which is we do endovascular treatment on people that have large vessel occlusions that fall within the 6 to 8 hour time window and who either can't have IVTPA or don't respond to IVTPA.